Or another week here of our COVID-19 update. It's my pleasure to be talking to you for yet another update on COVID-19 best practices. I'm filling in part for a second here for Karen as she's having some IT problems here just now, but we're going to go ahead and get started here. Just a quick introduction of myself, Anthony Harris. Board certified in occupational and environmental medicine, serve as the Chief Innovation Officer and lead doctor for COVID operations for WorkCare. If you're joining us for the first time, welcome. WorkCare is a full service occupational and environmental medicine clinic based out of Anaheim, California. So we have operations throughout the US and operations also in Canada and Mexico now. So we're happy to talk to you once again here for, I think this is our 23rd, perhaps week here in a row for providing this service and this offering for best practices. So without further ado, we'll go ahead and jump into this. Today, we're going to spend a little bit more time to give opportunity for questions and answers, okay? So hopefully we'll get through the presentation here a little bit more expeditiously today so that we can really get into some details on the questions. So if you haven't done so in the past and you're looking to ask questions, you can do so by clicking the Q&A button on your Zoom meeting here. And we will, at the end of the presentation, get to those questions and go through as many as we can. We typically take about half an hour for the presentation, but again, today we're going to try to expedite that so we give a little bit more time at the end for question and answers. So if you, again, are joining us for the first time, our format is pretty straightforward. Clinical update comes first, followed by an update with some pathology, microbiology. We talk about vaccinations and other things during that segment as well. And then we'll zoom into the numbers, both on the macroscopic and microscopic scale, looking at globally and US-based statistics from an epidemiology standpoint. Finally, we'll get to the prevention and the workforce strategies as they pertain and germane to WorkCare, as well as just kind of a global approach, okay? So we'll jump into the clinical update for today. The update we want to focus in on today is updating you on reminding of the effects of having children re-enter the school environment and what the implications of that may be, okay? And we really want to emphasize a couple things when we talk about children and what they encounter with COVID-19. Now, in fact, children can have any of the symptoms that you see on the left side that you're familiar with historically of COVID-19. So I don't want to suggest that they cannot have these symptoms. They absolutely can. But what we know to be true when we talk about what children are experiencing is that most of them have very mild disease, if any symptoms at all, okay? And if we look at what is reported, not just from CDC, but a multitude of sources in regards to COVID-19 experience of children, it really is focused in on two symptoms in particular. Those symptoms include cough and fever, okay? So the majority of kids that experience symptoms have a cough and a fever. And then when we talk about the number of kids that actually experience symptoms whatsoever from COVID-19, if at all, up to 45%. Now, there's other literature that point towards that being in excess of 50 and higher percentages of the percent of kids that experience no symptoms whatsoever. But we just need to keep that in mind because as kids go back to school, we're sending, my wife and I are sending our 3-year-old to preschool starting next week for the first time, right? And so we're keeping in mind what are the best practices for protecting kids at school, as well as what are the things we need to look for that we can't simply dismiss in regards to how she presents clinically. So when we talk about now the update for the pathology and microbiology, we're going to focus in on an update for testing, okay? And this is testing that hopefully you may have heard of in the last week here, but testing that you need to be aware of because it really is going to be hopefully a game changer in terms of access to testing in the US. And this is an effort, it's called COVID Tracker and it's called Saliva Direct in terms of the specific test. And this specific test is a saliva-based test, as it suggests in its name. It just received FDA EUA authorization as of August 15th. And this test is going to be as simple as some of the other saliva tests that you may be privy to. There's about 3 or 4 that are growing in popularity. We're using a particular saliva test at work here and have done thousands of them, almost probably tens of thousands at this time in distribution. And they work well, right? But there are some advantages to this offering that we want to point out. So in this FDA emergency use authorization, this test in particular came out of Yale School of Public Health. And their whole approach was, how do we accelerate testing in the US to the levels that we need to do adequate preventative measures as well as surveillance measures? The test itself, to get a little technical, again, saliva-based, but not terribly complex in how the test is rendered. The saliva is provided. It's mixed with a couple reagents, and these reagents then are activated and are maintained in a heat environment. And the environment of the heat is just a simple water bath, warm water bath, or a heating device. And the device is just a warmer, so to speak. And then the classic application of RT-PCR, quantitative PCR is the Q part of it, is performed, okay? And so this test is a game changer, primarily because it's not a kit that you can purchase and go out and start testing your employees. Rather, it's a methodology and an approach that laboratories can adopt to do testing at a scale and with simplicity of just providing saliva. Okay, and so that's why it's a big game changer, because it's made and designed to actually apply across the board to any laboratory that endeavors to apply this technology to their facility in the US. All right, and so this is a scalable opportunity for access to this type of simplistic collection as well as processing of the samples. And so it's even going to be FDA, they're going for FDA waived, CLIA waived certification, meaning that you don't need complex certification to utilize this methodology. And so the other game changer is cost, right? If the reagents that are listed here, they are broken down by cost. And at the end of the day, the total cost is between $1.29 to $4.37 in regards to the cost of performing one sample analysis, right? And so now imagine, and this is particular to this effort with this non-for-profit from Yale, they want to decrease and bend the cost curve for testing in the US. And so they have stipulations on any laboratory that signs up for this type of capability, such that they have to pass through those costs to their end users or customers, okay? And so we are going to see, hopefully here in the coming weeks, this escalate in availability and be a tried and true pathway for us to do scaled up testing on a regular basis amongst our workforce. So keep an eye out, and obviously we'll keep you informed of opportunities to leverage this as a solution from WorkCare ourselves. Let's jump into the epidemiology and look at the numbers as they have grown, obviously, over the last couple of days. If we look at where we were on the 5th of this month, 4.6 million cases, 155,000 deaths, went up to and over 5 million cases on the 12th. And then we are sitting at right under 5.5 million cases as of today, with almost 170,000 deaths. Obviously, still leading the way in the world in terms of number of cases here and mortality. If we look by jurisdiction, where we were 2 weeks ago, where we were 1 week ago, and then obviously where we are today, we're still seeing increased numbers of deaths as a result of COVID-19 from state to state. And the curve that we've been watching over the last several weeks here, as it stood 2 weeks ago, this is a 7-day rolling average for number of new cases that it presents in the U.S. specifically. We saw that number grow, crest, and then begin to decrease in terms of daily new cases. And as we look at this week, we see that decreased trend still occurring. All right, so obviously a little sunlight, if you would, or sunbeam of hope in regards to hopefully getting control of COVID in the coming months. If we looked at how we're doing at the global level, again, we're still leading the way in terms of number of cases. This is where we were 2 weeks ago, back on the 5th, where we were as we saw some decline in regards to the cases here with new confirmed cases, 7-day rolling average. And then where we stand today, we still see a slight decline in that slope of the number of cases on a daily average. So when we talk about then the number of deaths and the trend on a 7-day rolling average, we've been watching this statistic for some time now. We saw it increase along with the increases in incidence. We are seeing that decrease trend from 2 weeks ago to a week ago on the 12th, and now to the 19th. We're seeing a little leveling of that downward trend. So we want to pay attention to see if that begins to increase in number as we move forward here. If we look at then and continue to examine, are we doing enough testing in the U.S.? We look at first the global picture of where testing exists and the percentage of positive cases for the number of tests conducted. And this is a 7-day rolling average as well. From week to week, we saw a slight decrease, right, from 2 weeks ago where we stood to last week, with the United States being just below India in terms of percent of positive cases. And then we're looking to this week, seeing a downward trend, a more definitive downward trend, which is in this case, obviously good news, right? We want to see a lower percentage of positive cases for the number of tests being conducted. And that signifies that we are more accurately articulating the burden of illness in the US compared to where we historically have been. Obviously, we still have a lot of room to go because the United States here is still far above in terms of percentage of positive cases, above Italy and Germany, Norway. If we look at that decline here, we can see it articulated more prominently in isolation. But then we look at New Zealand, right? I mean, they're on the floor in terms of number of new cases that they've had in the community. And in fact, you may have seen in the news that New Zealand went 100 days without any community coronavirus transmission. And so it begs the question of, what did they do to get the performance that they have in regards to preventing community spread of COVID-19 in their community? And so the answer is pretty straightforward. Early on, we saw New Zealand do a tremendous job of locking down the social distancing piece of it, right? They prevented individuals from even driving and leaving their neighborhoods across the country. And the early adoption of these strict policies propagated to the point where individuals were only on lockdown for 28 days roughly, right? So in the matter of a month, they were able to maintain their strong social distancing. They did not actually mandate masks and still don't across the nation. But again, because they adopted such stringent measures early, they were able to ease their restrictions several months ago. They are almost pretty much back to normal, and they're still experiencing no transmissions. Now, there are some other factors that play out in regards to their success. One being population density. If we look at New Zealand compared to the US, New Zealand has about only 18 individuals per kilometer in terms of population density. In the US, that's up, we're sitting around 32 to 36 people per kilometer. If we look at nations across the pond and nations east, like India and in the UK, the numbers go up to around 60, and in India's case, over in the hundreds of people per kilometer in terms of population density. So that does play a definitive factor in that mode of transmission in terms of person-to-person contact, right? But we also want to learn from this experience in terms of being proactive and being very fast moving with regard to those restrictions for social distancing, and looking to that as a means to still turn around the increased numbers that we're seeing day to day and week to week here in the U.S., as we have seen states re-enter lockdown mandates. So as we talk about prevention here, we're gonna hopefully wrap things up, like I said, a little early today so we can get to more questions this time. But this map is depicting legislation germane to COVID-19 and protecting either workforce or protecting the general population. And the darker the blue that you're seeing here on this particular map signifies the increased number of volume of legislation, pieces of legislation authored, okay, and adopted. And so you can see New York and Minnesota lead the way. California does as well in terms of pieces of legislation. But we want to be specific here as well in terms of states that have authored legislation on the workforce, on employers, and mandated that employers have in place certain pieces of prescribed methods for preventing transmission in the workplace. Obviously, Virginia, we talked about that 7 weeks ago, and we want to focus in on Oregon, as we knew Oregon was quickly approaching their clearance or adoption, excuse me, of legislation. And Oregon has gotten pretty specific. And thank you, Karen, for sending this over as we look to understand what these different pieces of legislation are imposing on employers in Oregon. And we want to be specific in this opportunity so that you're prepared for a potential legislation authored in states that you're active in operating, right? Because again, under penalty of law and up to $130,000 fine, if we're talking about Virginia, is what we're contemplating here from state to state as they author legislation. So let's quickly zoom into some of the points here so that you can see the level of detail that the legislature has put into these mandates for employers. Mandated social distancing. So you have to maintain 6 feet. You have to actually design your job to eliminate the need to work adjacent to someone within that 6 foot range. And if you can't, you have to mandate some type of barrier, or you have to mandate facial covering. Okay, and so these mandates are hard. You can't get around them in Oregon in particular. Another example that we want to highlight here, again, face coverings when you for not just your employees, but for any contractor or any customer that is on your premises, and not just your main facility, any facility that you may operate out of or control, you have to have these measures in place, and it's specific to the exposure level, right? We know exposure is cumulative in regards to potential transmission from one person to the next. So within 6 feet for 5 minutes or more, if you can't keep people outside of that parameter, you have to mandate face coverings, and even brief encounters with another individual, right, at work is going to be cumulative. So that if we pass by each other and that in passing is only 2 minutes, if that sums to more than 30 minutes in a day, then we are mandated to have face coverings in place, right? And we work with employers and have talked about this very topic and whether or not face covers are needed or not. And so now states are saying, no matter what, you got to put them in place, even if you have these cumulative exposures in brief moments. And then one of the last things about these face mask requirements, face covering requirements, even when you're transporting someone in a vehicle, they're saying you got to have social distancing in some cases, but mostly you have to have a face covering in place. If we look at then other mandates from this legislation, high contact surfaces mandated, they must be clean prior to the beginning of each shift. They're mandating that 25, if you have 25 or more employees, you have to designate someone to be responsible for policing, so to speak, the social distancing and face covering use in your facilities. Okay, so now you have to have basically a COVID compliance officer at your facilities. And we've seen this in other industries like the media and movie industry, where a COVID compliance officer is a must if you're operating. And then we're also seeing that you have to have education prominently for the employees about COVID hazards, right? Posters, but specifically, you gotta have social distancing education. How do you maintain it? What scenarios, etc. You also have to educate about policies and procedures that explain these safe practices. And then you have to also educate them on and have in place means for medical removal, right? Symptom-based, ongoing testing, etc. You have to educate on quarantine, what's appropriate, and you have to do so in a way that also provides someone, if they're medically removed, with paid leave. And this is specific to Oregon, right? There are one or two exceptions here, but if you have someone out, you have to provide paid leave, even if you're exempt in other scenarios from the federal standpoint. And it's a 2-week paid leave. So I point these out so that you're aware of them, that you're prepared to hopefully endure some of these and be compliant with some of these policies and procedures that are going to be mandated by law. And simplistically, we want to distill it down to what's a good acronym, or what's a good mantra to hold with employees and you as an employer as we talk about communication and education to your workforce. And we're going to talk about E equals MC squared. And no, we're not going to get into Newtonian physics and talking about Einstein's brilliance, right? But we do want to talk about education of the workforce and how that equals a management plan. We want to talk about communication and then the clinical support, right? And we can boil that down to the E equals MC squared equation here. So we want to make sure you're focused in on, as we approach the fall, to reduce absenteeism, a management plan for home and work, right? And most of you by now have some type of plan for the work setting, but also we want you to communicate to employees that having a management plan for the household is going to bear fruit in regards to reducing absenteeism if they can devise it now before the issue arises, right? Then we also want to talk about early communication of COVID-related changes that may occur in the household, as well as work, obviously. And then finally, rapid access to clinical support. Map it out, make sure that you have the process in place for your employees so that they can get the appropriate care at the appropriate time, earliest appropriate time, to hopefully minimize transmission, as well as get individuals back to work as soon as possible. And so we can look at this in the auspices of our primary, secondary, and tertiary prevention. And if we focus in on the primary prevention, we want to make sure we're communicating establishment of a safe home practice, right? And get specific when we talk about coaching and educating your employees. Get specific, right? Wearing face coverings, when to wear them, when you go out to a restaurant, when you go out into the community. Best practices around social gatherings, family gatherings, the numbers that are not appropriate, and then obviously wearing face masks in those settings, and then actually play out case scenarios, right? What happens if my child gets sick? What happens if my spouse gets sick at home? Educate them on devising a plan so that we know what room we're going to keep that individual in. We know how we're going to keep the house clean, and we have the appropriate materials at home to do the necessary cleanliness activities right in that scenario. So we want the employees to plan and map out the what ifs, so that if it does come to pass that someone is affected by COVID in their household, they have a plan and they're much more capable of reducing transmission. And obviously this will help reduce absenteeism by protecting your workforce when they have sick contacts at home. Secondarily, in that secondary prevention, we want to talk about determining when and how to communicate, when and how to communicate, and have a plan for communicating. First, the when, right? Communicating the day of symptoms, right? Not waiting until, oh, I was symptomatic over the weekend, I'm going to wait till Monday to communicate. Communicating as soon as possible when you're ill or you have a household member that becomes ill, so that we can talk about what preventative steps need to happen right away. We also want to communicate the when of resolution of symptoms, right? Not waiting too long, and also not communicating too soon. That may bottleneck the system in terms of HR or access to your communication with your healthcare provider. And then new sick contacts and exposures. We want to make sure the when of that is precise, right? That individuals know, workers know when to communicate this information. And then how is what medium do they use, right? Do they pick up the phone? Do they send an email? Do they send a text? Do they contact their healthcare provider and then in part have the healthcare provider reach out to the HR, to the supervisor, et cetera? All this needs to be mapped out and communicate to the employees so that they know the game plan before the situation arises. And getting this right in the fall is going to help ensure, again, decrease absenteeism by reducing the amount of time individuals are out unnecessarily. And then finally, in that tertiary prevention bucket, the clinical support pathways. When someone develops symptoms, how do you access the clinical support? Whether it's local, whether it's work care and you're picking up the phone, or you're filling out a survey online, or taking a daily symptom checker, right? We want to make sure that these pathways are crystal clear to employees so that they have the resources at their fingertips if they should fall ill or have some of these exposures at work or at home. Right, testing options, we want that to be mapped out as well, right? What tests they're going to get if X scenario happens. It shouldn't be a mad scramble to get someone tested after the fact.
Hey,
right?
Doctor, your face away. Are you walking?
No, it may be my internet again.
We'll lose you.
Hey, can you hear me now?
Yeah, that's better. Thanks.
Okay. Hey, thank you. Thanks for letting me know. So we want to make sure that the testing roadmap is in place, and there's no question about what tests will be performed and when, right? And employees should know that scenario so that they can be expectant if the worst case scenario should happen. The quarantine and self-isolation, obviously we want to make sure they know when to quarantine, know how to quarantine in conjunction with communicating with their employer's choice for clinical support. And we want to make sure that happens and they know the expectations so that we don't continue to see what we're seeing with some employers in which individuals are staying out too long because they don't know that they should be back on X and X date, right? And that wasn't communicated up front. And then the return to work piece of it, obviously, getting people back as soon as possible should be communicated up front so that, again, we're expectant to the expectation of communicating with that clinical support. So all these things are germane to how we're going to get through the fall, how we're going to educate our workforce and make sure that we're doing our best in terms of practice for COVID management. And this shows up different ways, right? If we look at what some community hospitals are doing, in this case, Mad River Community Hospital, they have an algorithm, right? Are you feeling sick? If yes, are you at home? If no, etc. Do you have risk factors? And these are posters and education campaigns that they put forth. We have playbooks the health department in Utah put out very thorough playbooks for both the employer as well as the school setting. And they talk about how to train your employees. They talk about playing out those scenarios that I mentioned earlier, where you help walk your employees through case scenarios of sick household members, sick community exposure, etc., so that they know what to do when and if that time should arise. And then finally, simplicity is always best, right? Keeping it as simple as step 1, step 2, step 3 on any given piece of that primary, secondary, and tertiary prevention, and when to act and how to act. And with that, I'll stop. Well, let's open it up to questions because I want to get to as many as we can, hopefully a little bit more today than we have been able to in previous sessions here. Thank you.
Okay, thanks, Dr. Harris. And this is Karen O'Hara, who is usually your host for this session, but my internet knocked me right before we were going to start. So I apologize for that. But let's jump right into the questions. And the first question, I actually wanted to direct you to a frequently asked questions document we just posted yesterday that answers all your questions about masks, including the Duke University study, which found that gaiters are not effective in blocking the dispersal of viral particles because they don't have double layers and they're not really tightly fitted to your face. So unless Dr. Harris has more he wants to add on that, we'll jump into some of the other questions.
I'll just add that the gaiters actually may increase the number of particles that become aerosolized. So not only did the study find that they were ineffective, it actually showed evidence that they may increase the rate of aerosolization of viral particles because of the porosity of the material. So stay away.
Okay, so that let's jump into some questions about the saliva test, the direct saliva test, which you started off with. What is the turnaround time for saliva direct testing?
So the turnaround time in terms of processing the sample once it arrives at the laboratory is only 30 minutes, right? The other logistics around that particular laboratory's ability to both receive the sample, process, and then transmit the results to you as the employer or as the patient will be, variable per laboratory. But the guts of the actual process itself only takes 30 minutes.
Okay. Someone wants to know if they can buy this equipment and do it at their facility and skip the lab.
If you have a clear waived operation where you're able to perform these type of tests in your facility, then the answer is yes. You can apply to do this type of saliva analysis if you qualify.
And what is the specificity and sensitivity of the direct saliva test?
It's in the
mid false positive, false negative, which is
in the mid to high 90s, and that obviously is what we want to see, in particular with the saliva test or any test to that fact. So it does have accuracy.
Okay, regarding the demographics you show for the number of COVID-19 tests that were conducted in the United States, the question is, the daily numbers that are positive tests that are repeat tests for people that are attempting to get a second or third negative test result in order to return to work?
That's a great question. The majority of those tests are not that scenario because across the board, most states are still only testing if you're symptomatic. And so as a baseline, multiple tests are not the bulk of that data. Now, certainly there is data associated with multiple tests that has not been delineated in some of the numbers that we look at in terms of multiple tests, but we know that it is definitely a minority of that data.
Okay. One person's asking if you can just put up the E equals MC2 slide again. So while we're answering questions, you can take a look at that.
Absolutely.
Thanks. Okay, thanks. And the next question, what are your thoughts on new guidance from the CDC that people who recovered from the virus can safely mingle with others for 3 months after recovery? That implies some degree of immunity.
Indeed, and that is the clinical wisdom as it stands today, that once you contract and recover from COVID-19, you're likely to have at least 3 months of immunity. And it may be longer, right? But what we're seeing is that data is pointing to at least that minimum for having immunity.
So do we expect that guidance to change over time as more evidence comes to light about the degree of immunity afforded after you've had COVID?
Indeed, I do believe that data will become, one, more accurate, and two, maybe lengthened, right? As time goes on and we see more prospective studies, as well as retrospective cohort studies, looking at who still had laboratory detectable immunoglobulin, IgG in particular, we can then extrapolate across the board how long then immunity to SARS-CoV-2 will be and may last.
Okay, here's a question about flu shots in flu season. I just wanted to mention that we also just published a fact sheet on the upcoming flu season, which is going to be occurring simultaneously with the pandemic and the vaccine trials for COVID. The question is, Safeway stores in my area in Northern California have signs out offering free flu shots. Isn't it a bit early, or is there a strategy to start offering them now?
I can't speak to that particular instance of offering the flu vaccination right now. In most places, the process has not started. The strategy that one may be deploying, however, could be that of getting people vaccinated early, because there is data that is showing, particularly out of Brazil, that we opined about, I believe, 2 sessions ago, that the 2020 flu vaccine, trivalent flu vaccine, may offer some protection against poor outcomes, mortality in particular, if you are vaccinated and contract COVID-19. So again, the strategy could be, let's vaccinate as soon as we can for this season of flu to help decrease mortality in those vulnerable populations or at-risk populations if they should contract COVID-19.
Yeah, one of the things I learned when I was doing research for that fact sheet was that you can get COVID and the flu at the same time, and I thought that sounded pretty horrible.
Indeed, you can, and that would be a double whammy for sure.
Yeah. Here's a question about data. Do you have confidence in the incident data being reported now, since as I understand it, the data/reporting are no longer being controlled by the CDC?
Sure, so the data is being contributed back to the CDC. The data has always come from, though, locally, the public health departments, right, at the county and state level. And so in regards to that data and the consistency of that data, I do have confidence that, and what we're seeing is that over time, we've gotten better at communicating that data versus where we were when this all first started. And we're seeing more and more health departments performing surveillance testing in different ways so that we are better articulating the incidence of disease in the US. And the statistic that we look at from week to week, showing the percentage of positive cases for the number of tests performed, that number is improving, decreasing, which is indicative of, again, better articulation of actual incidence and prevalence of the illness in the U.S.
And we have time for one last question, and it is our last question. Do you have any updates to the classifications of an OSHA workplace recordable related to the more probable than not, i.e. greater than 50% certainty, that the exposure occurred at work?
So this question, I believe, is getting at the notion of presumptiveness, right? And I know a number of states have been looking at, is there a presumptive assumption, right, that COVID-19 transmission occurred at work if one of your workers should contract it? And there has been no consensus across the board. And many states that type of legislation or offering has failed. I believe that a practice of presuming work-relatedness carte blanche is not appropriate. We did talk about causality and the Branford Hill criteria. And we want to go back to that, looking at case by case, what is the proportionality attribution and likelihood of transmission for each case. And so, again, across the board, I do not believe there's going to be any move towards putting more onerous presumption on the workplace transmission likelihood, other than doing a case-by-case thorough analysis.
Okay, maybe at a future webinar, we could take a look at some of the workers' comp claim data. I was just reading today about how the majority of claims are emanating from the healthcare industry, but it would be interesting to see some comparisons with other types of industries and, you know, maybe by state. So that's something we could do if people are interested. So
Absolutely.
that wraps up our session today. We'll be back for week 24. Thanks again, Dr. Harris, for joining us today and for bringing us up to speed on the best practices. Everybody
Excellent.
Stay safe. Thanks for being here.
Thank you, everyone. We'll see you next time, same place. Be safe. God bless.
See you next week.